Sorry, there was no voice. My microphone was muted. I'll repeat what I just said. So we were doing lithium toxicity. Now let's do an example how a person of lithium toxicity is going to present to us. A man with the bipolar disorder for 10 years and knee pain for which he takes ibuprofen develops tremor, vomiting, and confusion while traveling a long distance. So a man who is a diagnosed case of bipolar disorder, he is taking NSAID. Remember that we have discussed that NSAID can precipitate the lithium toxicity because NSAID do two things. One is that it increases the renal reabsorption of lithium, and number two is it decreases the renal clearance of the lithium. So that's why NSAIDs such as ibuprofen, they can precipitate the lithium toxicity. And the most appropriate investigation in acute toxicity is serum lithium concentration. While the long-term tests that need to be done in patient who is taking lithium is LFTs and KFTs after 6 months. So there are two most important drug categories that increases the serum lithium concentration, and they can precipitate the toxicity of lithium, and they include diuretics, ACE inhibitors, ARBs, and NSAIDs and metronidazole. So all these drugs, they can precipitate the lithium toxicity. Now some points about lithium and pregnancy. Remember that lithium is ateratogenic, and the use of lithium during pregnancy can lead to fetal cardiac malformations such as Epstein anomaly, thyroid disease, and floppy baby syndrome. So the use of lithium during pregnancy can lead to these three conditions. Now, if a woman is on lithium and she is planning to get pregnant, then we need to reduce lithium gradually and stop it before pregnancy is confirmed. Now, the second scenario is a woman is on lithium and she become pregnant. Now, in this scenario, again, we will consider stopping lithium gradually over 4 weeks if she is well. But if she is not well, then we would not stop lithium, and we'll continue the lithium while she is pregnant. What we need to do in that case, we need to check plasma lithium levels monthly till the 36 weeks of pregnancy, and then weekly till birth after 36 weeks of pregnancy. So three scenarios that we can encounter. Number one is a woman is on lithium and she's planning to get pregnant. We'll gradually reduce the lithium and stop before the pregnancy is confirmed. And if a woman on lithium becomes pregnant, then we'll gradually stop lithium over a period of 4 weeks if she's well. And if she's not well, then we won't stop lithium, and we'll check the plasma lithium level monthly till the 36 weeks of pregnancy, and then check plasma lithium levels weekly till birth. So again, a short summary of the points that we discussed before, that lithium levels are checked 1 week after initiating lithium for dose adjustment. And after that, levels are checked every 3 months. Kidney function test and urine electrolyte, they are checked every 6 months. So another example about bipolar patient on lithium was found to have a high serum lithium levels and hypokalemia. He recently started an antihypertensive medication. What is this medication? So bipolar patient was started on a lithium level, and now he has got high lithium levels and hypokalemia. So, which antihypertensive medication it is? We have discussed that NSAIDs, diuretic, ACE inhibitor, ARBs, they can precipitate they increase the serum lithium levels. So, depending upon the information given in this question, can you tell me which drug, which antihypertensive medication the person is using? The hint for you is that hypokalemia. So, which antihypertensive medication can cause hypokalemia?
Hyperkalemia, it's ACE inhibitors and spironolactone.
Spironolactone and
Hyperkalemia, na?
hypokalemia.
Hyperkalemia, it's diuretics. Loop diuretics has a diuretic.
So, which one of these? Yes, which one of these loop diuretic and thiazide diuretic? Which which one of these is used in the treatment of hypertension?
Thiazide.
Thiazide diuretic. So yes, it's bendrofluorothiazide, as Dr. Musarraf said. So the answer here is thiazide like diuretic or bendrofluorothiazide, which has led to this increase. Now, again, which tests need to be done before initiating lithium? Remember that two important tests that need to be done in every patient who are going to start lithium. That is thyroid function test, because lithium ions can affect the thyroid gland. It can cause hypothyroidism as well as hyperthyroidism. So we need to order a thyroid function test. We should have a baseline thyroid function test before initiating lithium. So now a summary of the tests that needed to be done before starting lithium. Two tests needed to be done. One is thyroid function test and the second is kidney function test. After starting the lithium, after first week, we need to do serum plasma lithium concentration. And after that, we need to do serum lithium concentration every 3 months and KFT and LFT every 6 months. Before starting thyroid function test and kidney function test, after starting kidney function test and LFTs every 6 months, and serum lithium concentration every 3 months. So don't forget these tests. Now there is another important point that you need to remember for Plab 1 is that sometimes in bipolar patient who is on lithium, an addition of an SSRI such as sertraline and fluoxetine. Remember that sertraline and fluoxetine, they are mood elevator. They elevate the mood. So a person with bipolar disorder, if he is taking SSRI as well, then it can worsen the episodes of mania. That's why if there's a scenario in which a person with bipolar disorder is taking an SSRI, then we need to stop if the mania is worsened. Bottom line is antidepressant precipitate manic episode. Now, as we discussed that lithium is a teratogenic, and if a pregnant woman is taking lithium, then there's a chances of Epstein anomaly, floppy baby syndrome, and thyroid abnormalities. Now, here is a diagram and a brief description of Epstein anomaly. You can see that Normally, the tricuspid wall is present here, but in Epstein anomaly, the tricuspid wall, you can see that it has moved downward. So the tricuspid wall is in the wrong position and the walls are malformed. So the Epstein anomaly is basically an anomaly of the tricuspid wall. Tricuspid wall is not in its normal position, which should be here. It is in a wrong position, and also the leaflets are malformed. As a result, the wall does not work properly, and the blood might leak back to these walls, making your heart less efficient. So this was a brief description of Epstein anomaly. Now, what is the mechanism of action of lithium? Why it is used in the treatment of bipolar affective disorder? First of all, you need to know that what happens in a patient with bipolar affective disorder. Patients with bipolar affective disorder have diminished GABA neurotransmission. Remember that GABA is an inhibitory neurotransmitter. And because activity of this inhibitory neurotransmission is diminished, so there will be excitatory toxicity. So this is basically the basic problem in bipolar affective disorder, that is diminished GABA neurotransmission. Now, what does lithium do? Lithium increases the level of GABA, which in turn reduces the excitatory toxicity. So there are two receptors, one is GABA and the second is NMDA receptors. In bipolar affective disorder, the activity of GABA is decreased and the activity of this excitatory neurotransmitter NMDA, it is increased. And what does lithium do? It increases the level of GABA and decreases NMDA receptors. So that's why it is the gold standard in the treatment of bipolar affective disorder. Now here is a diagrammatic representation of the mechanism of action of lithium. Lithium, you can see, is increasing the GABA levels. It also facilitates the GABA release, and it also upregulates the GABA receptors. So from presynaptic neurons, it causes an increase of GABA levels, increased release of GABA, and on postsynaptic neurons, it upregulates the GABA receptors. So this was all about bipolar affective disorder and its treatment and the toxicity of lithium. Now our next topic is schizophrenia. Now remember that as we discussed that in bipolar affective disorder, GABA level decreases and excitatory toxicity can occur, which lead to these signs and symptoms of bipolar affective disorder. Now in schizophrenia, the hormonal disturbances, the problem is in the dopamine. Basically in schizophrenia, dopamine levels are increased. Due to increased dopamine levels, the person get these symptoms that are divided into auditory hallucination, thought disorders, passivity phenomena, and delusional perceptions. So four types of symptoms can occur in schizophrenia, that is auditory hallucination, thought disorders, passivity phenomena, and delusional perceptions. Now, first of all, we'll discuss about auditory hallucinations. There are three types of auditory hallucinations. Auditory hallucination is the patient will hear voices. Now, there are three types of auditory hallucination: first person auditory hallucination, second person auditory hallucination, and third person auditory hallucination. Now, third person auditory hallucination, they are usually the commonest in schizophrenia. Now, what is third person auditory hallucination? Third person auditory hallucination means the patient will hear two voices that is talking about his or that is talking about him or her. So two persons will be talking about the patient. For example, uh, the voice is heard saying, "He is evil. He is moving. She is opening her phone. He is getting up. Now he is going towards the window." So this is called third person auditory hallucination. Now a second person auditory hallucination. What does a second person auditory hallucination mean? A second person will be talking to the patient, or a person will be talking to the patient. In third person auditory hallucination, two people or two voices were talking about the patient. Now, in second person auditory hallucination, one voice will be talking directly to the patient. For example, the patient will hear saying that the voice will be saying to him, "You are evil, you are moving, you are opening your phone." So this is an example of second person auditory hallucination. Now, what is first person auditory hallucination? First person auditory hallucination is when the person hear his own thoughts. For example, I am lying down, I am moving, I am evil. So this type of hallucination in which the person hears his own thoughts is known as first person auditory hallucination. Now it can be divided into thought echo and the second type is a very difficult name. I don't know how to pronounce it. So what is thought echo? Thought echo is the patient has a hallucination of hearing his or her own thoughts a short time after thinking them. So if the patient hear his own thoughts, a short time after thinking them, then it will be known as thought echo. And if the patient hear their own thoughts at the time they are thinking, so the thoughts are here at the time they are thinking, then it will be known as this. And if the thoughts are here short time after thinking them, then it will be known as thought echo. So this was all about auditory hallucinations.
Can you repeat it again?
Yes.
Can you repeat it?
Can you please speak a little louder?
Can you repeat it, doctor?
Okay, I'll repeat it. So auditory hallucinations, they are divided into three categories: third person auditory hallucination, second person auditory hallucination, and first person auditory hallucination. Third person auditory hallucination is when the two persons are talking about the patient. For example, two voices are talking with one another about the patient, that he is evil, he is moving, he is opening his phone, he is getting up. So if two voices are talking about the patient, then it is third person auditory hallucination. And if there is only one voice that is talking directly to the patient, such as "you are evil, you are moving, and you are opening your phone," then it is known as second person auditory hallucination. And if the patient hear his own thoughts, such as "I am lying down, I am moving," then this is known as first person auditory hallucination. Now it can be further subdivided into thought echo and this phenomena. So if the person hear his own thoughts short time after thinking them, then it will be known as thought echo. And if he hear his own thoughts at the time of thinking them, then it will be known as this phenomena. I hope it's clear now.
Yeah, okay, doctor, I understand.
Can you please repeat the this cause of schizophrenia, like the same for
The cause
GABA?
of, yes, the cause of schizophrenia. Remember that the cause of depression is uh, low level of neurotransmitters such as serotonin, epinephrine, dopamine. All the neurotransmitters are decreased in the uh, depression. While in bipolar affective disorder, GABA neurons or GABA receptors or GABA neurotransmitter, they are decreased.
Right.
Now, the third condition that we are discussing is schizophrenia. In schizophrenia, the basic chemical abnormality is increase in the level of dopamine. That's why in the treatment of schizophrenia, we use antipsychotic agents, which are dopamine receptor antagonists. Because in schizophrenia, there's increased activity of dopaminergic neurons, which are causing all these symptoms. And the first of them was auditory hallucination. Now, the second one is thought disorder. Now, thought disorder, it is divided into four categories. That is thought insertion, thought withdrawal, thought broadcasting, and thought blocking. So auditory hallucination plus thought disorder. Now, what thought disorder is further subdivided into thought insertion, thought withdrawal, thought broadcasting, and thought blocking. Now, what is thought insertion? A delusional belief that thoughts are being placed into the patient head from outside. Patient thinks that someone is putting thoughts in his mind. This is thought insertion. And thought withdrawal is a belief that the thoughts have been stolen, taken out of his or her mind. Thought broadcasting means thoughts of the patient are being broadcasted. They are accessible to everyone. So whatever the patient is thinking, uh, he has a delusional belief that his thoughts can be accessible by anyone. And thought blocking is a sudden break in chain of thoughts. For example, a person is talking about a topic. Let's suppose he is talking about a disease. Then suddenly his speech is interrupted and there is a brief moment of silence. And now the person will start to speak again, but the topic this time would be different. So this is known as thought blocking, that a sudden break in the chain of thoughts. Before the break, the patient will be talking about a topic that is different from the topic that the patient will be talking about after the break. So this is known as thought blocking. So auditory hallucination were divided into third person, second person, and first person. And thought disorder, they are divided into thought insertion, thought withdrawal, thought broadcasting, and thought blocking. Now, the fourth symptom is passivity phenomena. Now, what is passivity phenomena? Passivity phenomena is that the person thinks that his bodily sensations, such as movement of his body parts, or pain, or any sensation that is controlled by external influences or someone else, and they are not in the control of the patient. So this is known as passivity phenomena. That is, bodily sensations are being controlled by external influences. Bodily sensation include actions, impulses, and feelings. If a person thinks that they are controlled by external influences, then this is known as passivity phenomenon. Now, the fourth symptom is delusional perceptions. Now, what is delusional perception? Remember that delusional perception is a two-stage process. Firstly, a normal object is perceived. Then, secondly, there is a sudden intense delusional insight into the object's meaning. For example, a patient see a traffic light is green. So this is a normal perception or normal object perception that the traffic light is green. Now, after the traffic light become green, the patient think that, for example, he thinks that I am the king. So this is known as a delusional perception. Delusional perception is a two-stage process. In the first step, there's a normal object perception, and in the second step, there's a delusional insight into the object's meaning, such as when the traffic light turn green, the patient think that I'm the king, or such as if the traffic light turn green, the patient think that his mother is calling him. These are the two common examples which will be asked in the Plab 1 exam about delusional perception. So this was all about the symptoms that are present in schizophrenia, that is auditory hallucination, thought disorder, delusional perception, and passivity phenomena. Other features that can be present in schizophrenia is impaired insight. The person does not know that he has these symptoms. And again, mood incongruity, mood incongruence, that is also a feature of bipolar disorder. It can also be a feature of schizophrenia. Inappropriate emotions for circumstances or incongruity, mood incongruity, it is present in schizophrenia as well as in bipolar affective disorder. Other symptoms, they include neologism, that is the person make up new words, catatonia, motor symptoms, and negative as well as positive symptoms. So positive symptoms, what are why they are called negative and positive symptoms? Positive means the changes are added onto the person's experience, such as hearing voices, which is not normally present. In normal people, hearing voices or paranoia is not present. So that's why these symptoms are called positive symptoms, because they are added to a normal phenomena. Along with normal phenomena, these symptoms are also added. That's why they're called positive symptoms. And what are negative symptoms? Negative symptoms are the things that are taken away or reduced. For example, someone with normal emotions and he normal motivation, and his motivation is reduced, or there is reduced intensity of emotion. So some things that are taken away from the normal process, they are known as negative symptoms. So the negative symptoms, they include incongruity, blunting of affect, anhedonia, that is inability to derive pleasure, elogia, poverty of speech, and poor motivation. And positive symptoms, they include paranoia, hearing voices, etc. And catatonia means it is basically a group of symptoms that usually involve a lack of movement and communication, and can also include agitation, confusion, and restlessness. So muscular symptoms can also be present in patients with schizophrenia. So along with auditory hallucination, thought disorder, passivity phenomena, these symptoms can also be present. Now, what is the treatment of schizophrenia? Oral atypical antipsychotics are the first line treatment option for the management of schizophrenia. Oral atypical antipsychotic include olanzapine and risperidone. Olanzapine and risperidone, they are atypical antipsychotics or second generation antipsychotics. The first generation antipsychotic, they include haloperidol and other drugs, while olanzapine, risperidone, they are second generation or atypical antipsychotics, and because they have less side effects than first generation or typical antipsychotics, that's why they are the first line in the treatment of schizophrenia. CBT can also be offered to all patients. Benzodiazepines are only used in patients with schizophrenia when a rapid tranquilization is needed. Close attention should be paid to cardiovascular risk factor modification due to high rates of cardiovascular diseases in schizophrenic patients, usually associated with antipsychotic medication use and high smoking rates. So we need to monitor cardiovascular system in patients who are taking antipsychotics. Now, what are the factors that indicates poor prognosis in case of schizophrenia? There are 5 factors. If they are present, if any of them is present, then they are linked with poor prognosis, that is low IQ, pre-morbid history of social withdrawal, lack of obvious precipitant, strong family history, and the most important point is strong family history. So strong family history is a poor prognostic factor if it's present in patient with schizophrenia. And gradual onset of the disease is also a poor prognostic factor. Now, there's a difference, a slight difference between delusion, hallucination, and illusion. Now, illusion is basically a false belief. A false belief or a false thought, while hallucination and illusion, they are seeing things. So seeing a thing when there is no stimuli, for example, seeing a snake when there is nothing, this will be known as hallucination. Without the presence of any stimulus, if we see anything, then this is known as hallucination. And if there is an external stimuli, such as we see a rope as a snake, then it will be called as illusion. So there's a slight defect between delusion, hallucination, and illusion. Delusion is basically a false thought or false belief, while hallucination is seeing or hearing things that are not present in the environment. While illusion is seeing something that is present in the environment as a different thing. For example, a rope is seen as a snake, it is an illusion. And seeing a snake is a hallucination. Oral antipsychotics are the first line, and if the patient is non-compliant, then depot injections can also be used. And if the schizophrenia is treatment resistant, then ECT can also be tried. Now, some variants of schizophrenia, that is schizoaffective disorder and schizophreniform disorder. Now, what is schizoaffective disorder? Schizoaffective disorder is schizophrenia plus mood disorder such as depression or bipolar disorder. So if someone has feature of schizophrenia plus there are feature of mood disorder such as depression and bipolar disorder, then we will call it as schizoaffective disorder. On the other hand, if the symptoms of schizophrenia last for less than 6 months or 6 months, then we will say this is schizophreniform disorder and not schizophrenia. So this was all about schizophrenia, its management. I hope it's clear to everyone.
I have a question about delusional perception, the 2 stages. Like, I mean, you mentioned that the person, if sees a green light and they think they are king. So how is it like? Is it generally the person see the things and then they believe that they are king, or is it like is a kind of hallucination that they're seeing a green signal?
No. The first step will be a normal process. It will be not hallucination or delusion or anything like that. Normal perception is associated with delusional thoughts. For example, if the patient with schizophrenia is driving and he stopped at the red light, and when the light becomes green, then he will think that, so light becoming green is a normal perception. Then he has associated something with this light becoming green, and that is I am the king. So